Dear Chairman, dear colleagues, I would like to take the opportunity to have this podium to present our work about the database analysis. As it has been, I have no disclosure conflict of interest to disclose. As it has been very well known, there are many advantages of VATS, and it has been well established. It causes less blood loss, less pain, shorter hospital stay, lower systemic inflammatory response, less complication, almost no chronic pain is observed after the surgery. And some publications pointed out that VATS leads higher survival in patients who had non-small cell lung cancer, but it is yet to be confirmed. And there are many studies comparing two strategies, two approaches, open surgery and the VATS, and also there has been numerous meta-analysis showing that this phenomenon, that the VATS leads to better results in terms of postoperative quality and also maybe in terms of survival. And it has been confirmed by a number of guidelines that in stage 1 patients, VATS should be first and it should be performed if it is possible in a specific center. And also it has been well established that VATS leads to, as I said before, lower inflammatory response, and maybe it is a way to get higher survival in the patients who had non-small cell lung cancer. It has been almost one decade that it has been described as the gold standard in early stage lung cancer patients. And also in octogenarians, in elderly people, more and more centers reported that the VATS could be a better option for resection, and since it leads to better results, maybe we can change our threshold for the patients who are elderly or for the patients who have limited pulmonary function. So our observation was that VATS patients do better, tolerate better, and for this reason, our hypothesis is that VATS must be performed older patients with more limited function and worse performance status. In order to test this hypothesis, we wanted to use ESTS database. And our second hypothesis, our second aim was that by VATS, classical preoperative cardiopulmonary reserve evaluation algorithms can be modified. Actually, we wanted to challenge the current preoperative evaluation charts or algorithms, because current algorithms clearly stated that if the patient is expected to have lower than 10 milliliters per kilogram per minute VO max, the patient should refer to possible oncologic treatment or SBRT. So we prepared our project proposal, and we sent this proposal to 2 senior international thoracic surgeons for suggestions. And then project proposal was presented to council and database committee. Project has been accepted, and then whole data was sent in June 2018. We have, of course, problems, and we have our solutions. First of all, we had to understand the data set, because it is a huge data set with a very large number of parameters. Deciphering some parameters was important. Understanding missing data, excluding the missing data, and analysis for exclusion was performed. Repairing and digitalization of some parameters were done, because some of the data were recorded as alphanumerical characters, and it was a little bit difficult to change the alphanumerical characters to numerical characters. And verification was done, and statistical analysis was performed. And we also analyze the data according to years. Longitudinal analysis was performed. And propensity analysis was thought to be necessary because large prospective data is a wonderful thing, but still it has limitations with patient selection bias. And of course, it depends on the centers that entered the data. And also, we are on the process of commenting on results and article writing. So we analyzed 63,219 patients. And as you see here, there were more male patients. The mean age was 64. Of course, lobectomy was the mostly performed procedure, followed by pneumonectomy and bilobectomy. There were 5,300 VATS resections, and we were able to analyze 12,579 VATS resection. As it was expected and as it was nicely presented by Professor Falkos, the number of VATS done by centers have been increasing during the last 10 years. As you see here, in 2017, it is almost same. The number is equal. The numbers are almost equal. And in terms of pulmonary function, FEV1, the mean FEV1 was 2.32%, 230 liters. FEV1 percentage, expected percentage is 85, and DLCO, the mean DLCO was actually was not low as expected. Mean ECOG was 1. This should be ESA score. Mean ESA score was 2. When we look at the results, actually, we realized that our hypothesis was totally wrong, because we found that VATS procedure was performed in the patients who had higher pulmonary function, not lower pulmonary function, and the difference was striking. Actually, the p-value was lower than detected levels detected by SPSS statistical program. So FEV1 was higher in VATS, FVC, percentage of FVC was higher, DLCO was higher, but there was no statistical significance. VO max also, surprisingly, was found to be higher in the patients who underwent VATS surgery. And ECOG performance status was higher in thoracotomy patients. Of course, VATS led to lower complications. As you see here, 27.4% of patients had complication in VATS group, whereas 35.9% of patients had at least one complication in the thoracotomy open surgery group. When we look at the CTNM staging for the patients, as expected, more and more patients with CT1 underwent VATS resections, and of course, C3 and C4 patients usually had open surgery. And usually, European surgeons tend to not operate the patients with N2 disease by VATS, and they usually seem to use thoracotomy for the N2 patients. And for the M metastasis status, it was almost same. Rates of CT1 tumors, of course, are higher in the patients who had VATS, as you see here, and it is true for all 11 years. When we look at the TNM stage, if it is higher, the patients usually have thoracotomy. I don't want to present all my slides because my presentation will take place tomorrow, but I am going to show you some couple of my slides. And when we look at the rates of patients with ECOG, again, surprisingly, more and more patients with higher ECOG performance status received thoracotomy, not VATS. So as it has been nicely shown by the latest study, VATS led to less complication, of course, and also it led to less impact on pulmonary function status. So it was, for us, it was fair to think that VATS was performed in the patients who had limited function. Of course, we have to ask the question, why better patients had VATS? We don't know the answer for this question, but maybe European surgeons performed faster surgery for sicker patients. This is one of the speculations. Educational factors might take a place for this result. Larger tumors maybe lead to limited lung function, but we performed a propensity score analysis and we found that even in the tumors, in the patients with larger tumors, thoracotomy was preferred over VATS in the T2 tumors and T1 tumors, of course. And maybe we were unable to internalize of the truth that VATS is better and it leads less trauma. Actually, we wanted to challenge this algorithm because, again, it clearly shows that if the patient has very limited lung function, documented by VO max, he or she should be referred to the oncological therapy or limited resection. If the VO max is lower than 10 milliliter, the patient should be referred to another option, therapeutical option. We used a large database and we really appreciated it, but we had some counterintuitive results. And as conclusion, what seems to be offered in older patients, and it seems to be offered to the patients with better pulmonary function. Real value of VATS should be internalized, and time for, I think, for data-driven patient selection. Maybe there is a need for mindset change, and large continent-wide database presents huge opportunity to ask very exciting questions, but we must prepare for the surprising results. Thank you very much for your kind attention.
Thank you very much. Any question from the audience? I'm just, sorry, Alex.
Just one. Well, running late.
Okay, but I'm just one short sentence that I don't think that the younger patient would be really happy if he hears that VATS should be only performed by older patients. There's certainly a place for younger patients. It's just
yes.
a short message.
That's what we thought before it, yes.
I agree with your initial hypothesis. I think the methodology is a little bit incorrect. We have seen that for sure, overall, in the ESTS database, VATS is still in the learning curve overall. So perhaps a better way to test your hypothesis would be to select those units with the high proportion of VATS, like above 50–60%, so in their mature phase, and compare it with units with a very, very low proportion of VATS or no VATS, and see whether there is this difference. So you eliminate the gray area where there are units that are starting VATS, and that there is the potential selection bias that these units select the better patients in their initial phase. So that's just a suggestion.
Yes, thank you. But as I will present the whole data tomorrow, we saw the same results in the recent years, 2016 and 2017. Of course, there can be some centers who did not complete their learning curve, but it didn't change a bit. And the difference is still very large in the patients. And also the difference is still, difference still persists in the propensity analysis, which was done by 200 patients. So yes, we have to look at it, but I think there should be a method to understand which center has completed their learning curve. And some centers, even the fact that some centers has completed their learning curves, maybe for the educational reasons, they can have higher morbidity or mortality rate in the patients who had VATS. So there is.
Okay, thank you. Sorry, Akif, we have to go on because we are running late. I would like to turn now to big data management.